Hello, and welcome to BasicstoBrilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the South West Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a Haemareg.
And let's get started on today's topic.
From basics
to brilliance. Okay, hi David, how are you?
Good, thank you. And yourself?
Very well, thank you. I thought we'd discuss a topic today of HIT, mainly because it comes up so much on call. And it's kind of a topic I think a lot of people know a little bit about, but not a lot of people know a lot about.
I'd definitely be in the former category and not the latter.
So I thought it would be a helpful one to cover in
Grand.
depth. I'd like to go into the sort of lab tests that we do, and I think the real kind of crux of this topic is about understanding the pros and the limitations of the tests that we've got, because essentially HIT is a really good example of a condition that's difficult to diagnose and manage because our tests aren't that great.
Yeah.
So I think that's worth bearing in mind from the beginning, and we can reflect on that at the end.
Sounds good.
Great. Okay, so I mean, let's just start with the basics. What is HIT? What does it stand for?
So from what I understand, it's heparin-induced thrombocytopenia.
Mm-hmm.
It has something to do with heparin binding to platelet factor, and that causes some kind of antigenic, inspiration to your immune system, and you end up with your platelets going down. So bad news.
Yeah, so I mean, we would classify HIT as actually a hematological emergency.
Okay.
And that often surprises people who phone me about it. You know, do you think this could be HIT? Often a sort of casual question at the end of the day. And actually, this is technically, if it is HIT, it's technically a hematological emergency. And the reason why is not because of bleeding, even though they get low platelets, but because of this really pro-coagulant state that they have due to this sort of autoimmune condition, essentially.
So it seems to be one of those themes, doesn't it? That when the platelets go down, they actually become more clotty for other reasons.
Yeah. Why? What other situation are you thinking?
Well, we were talking, remember in ITP when we were talking about, you're like, oh, they're such low platelets, but they were big, fat and sticky. So it was,
Yeah,
I guess it's one of those counterintuitive things.
Yeah, so with ITP, it's because the platelets are really fresh and new. In heparin-induced thrombocytopenia, it's actually because the pathological mechanism is leading to the activation of platelets. But essentially, we would say that it's a hematological emergency because you have associated with it a 50% clot rate, and that could be DVT, PE, acute coronary syndrome, a stroke or peripheral artery thrombosis. It's associated with a 20% or more mortality, which is high, and quite a high incidence of venous leg gangrene due to microthrombosis within a leg. Yeah, and you can get, in about 10 to 20% of patients with heparin-induced thrombocytopenia, you can get skin lesions at the injection site. So it is a really important condition that needs to be well understood and not missed. So you touched a bit on the pathophysiology, but essentially heparin is negatively charged. And then there's this other protein in the blood called platelet factor 4, which is positively charged. And when you get a certain ratio of heparin and to platelet factor 4, then they combine together and form a raft. And that forms essentially a neoantigen, a new antigen that the immune system hasn't seen. And so for some patients, you then form antibody, including IgG formation against the raft. And then this then leads to the formation of these tetramers between heparin, platelet factor 4, and the IgG antibody. And they then make these complexes which both bind to the endothelium and induce thrombosis, but also, more importantly, leads to platelet activation via their FC receptors. So via the receptor on the platelet, which is designed to bind the kind of action end of the antibody. And so then you get degranulation of your platelets and activation of the whole sort of thrombosis, the whole clotting cascade and primary activation platelets. And that's what then confers your increased risk of clots. So do you know what the optimal ratio is of heparin to platelet factor 4 to form these complexes?
I have absolutely no idea.
So it's a 1-to-1 ratio. And so actually we find that in excess heparin, you actually will dilute out the complexes that form. And that's relevant when we talk about lab tests later. So just bear that in mind. And I guess based on the knowledge of knowing that there's an optimal ratio between heparin and platelet factor 4 for HIT to occur, can you use this to explain why there's a higher incidence of HIT in cardiothoracic patients in particular?
So I imagine they are people that are being bridged from what I consider normal anticoagulants. So they might be on a heparin at a slightly higher dose than I'm used to seeing in our sort of general population, which might push them more towards a 1-to-1.
Yeah, exactly. So in cardiac ICU, during cabbage procedures and other things where they're put on cardiac bypass, the patient is flooded with heparin on bypass. And as the body then metabolizes that heparin, then they will inevitably pass through that window where the ratio is just right for the antibody complexes to form. Does that make sense?
Yes. Yeah, no, got it. Just a question. Is this within a population of people who are predisposed to autoimmune problems, or is this just a thing that happens?
That's a good question, and not to my knowledge, no. It is just a thing that happens to certain patients. There are known risk factors for heparin-induced thrombocytopenia. Do you know what they are?
No.
Okay, that's fine. So, firstly, unfractionated heparin is much higher risk compared to fractionated heparin, like low molecular weight heparin, like dalteparin or enoxaparin. Secondly, if you use treatment dose, then you're more likely to get heparin-induced thrombocytopenia compared to prophylactic dose. And that also kind of makes sense with the whole ratio thing.
Yeah.
As prophylactic low molecular heparin, there's probably not enough heparin around to make that raft and to make that neoantigen. Bovine heparin is much more, it induces HIT much more than porcine. So in the UK, we use only porcine heparin because you know where heparin comes from?
I'm guessing from the bovine and the porcine thing, we've got pigs and cows.
Yes. But it's more specifically, it's extracted from the gut of these animals. So
okay.
It's like literally mashed intestines, basically.
Delightful.
Yeah, so we use porcine rather than bovine because of the incidence of HIT. And then the other thing is if you're undergoing surgery or you've had trauma, then you're more likely to get HIT than if you're a medical patient or an obstetric patient. And I guess the reason for that is probably because if you're undergoing surgery or trauma, you've got quite a lot of inflammation already. So your immune system is sort of revved up, I guess, is how I think about it. So those are your known risk factors, and having other underlying autoimmune diseases doesn't really feature in that as your known risk factors. And I guess one other thing to just talk about then, based on it being an IgG antibody that forms and then mediates the disease, what do you think might happen if a patient who has had HIT gets re-exposed to heparin?
Yeah, so I'd be worried about a second instance in which you've got a bit of antibody already, so the response second time round might be a bit higher, as we've seen, sort of allergy kind of scenarios.
So, yeah, exactly, because essentially you've got memory cells. So what you're going to see is an anamnestic response second time round. So you basically, the first time you meet the neoantigen, you make an antibody. It's a slow response and it's less specific, and then you get a memory cell. But it means the next time you see heparin, you're ready and you go in and have a much higher peak in antibody, and therefore you would expect a much quicker onset of hit second time round for exposure, and that's reflected in the timings aspect of the 4T score that we will talk about in a bit. So basically understanding the mechanism behind how hit is mediated will allow you to not just have to rote memorize a lot of this stuff. So when you're on call and you're getting called about somebody having a falling platelet count and they happen to have had heparin, is it ever really hit?
I bet the amount of times you get called with people going, "Is this hit?" and you go no down the phone. Yeah. But I guess it's one of those that also you would be in a lot of trouble if you missed it.
Yeah, absolutely. And I'm joking, obviously, when I say no, it's never hit. But seriously, it is a condition that is overdiagnosed, or at least people try to overdiagnose it. And that's probably because there was a big education campaign a number of years ago to raise awareness of everybody to hit. It's something that most people have heard of and have a bit of awareness about. And also because there's a sort of a lack of reliable test, as I was saying at the beginning, it means that we may be overdiagnosing this condition. And actually the reality is only 0.7% of medical patients being given unfractionated heparin develop hit, and less than 0.2% of medical patients given low molecular weight heparin develop hit. So this is not a common condition, but obviously a hematological emergency. So as you say, something you don't want to miss. Why do you think it could be equally dangerous, though, to diagnose somebody as having hit when they don't have hit?
I guess the big problem is if we are worried about them being a big clotting risk, we mentioned 50% before, we're likely to go pretty hard on the anticoagulation.
Yes.
And if they're already on heparin and they don't have it and we go heavy on the anticoagulation, then potentially they can bleed in all kinds of areas, which doesn't sound great.
Yeah, exactly. So the risk of diagnosing somebody with hit when they don't have hit is that, yes, we are assuming, therefore, that they have all of the procoagulant nature of activated platelets in hit. And so as you've correctly kind of surmised, we treat hit with anticoagulation, with an alternative anticoagulation to heparin, but still an anticoagulation. And actually, therefore, it's potentially dangerous that we are anticoagulating someone with such low platelet counts sometimes, because we think that their platelets are activated and that they would balance it out. The other thing, of course, is that we label these patients as having to avoid heparin for the rest of their life. And heparin is a really useful drug. It's our standard VTE prophylaxis in patients, and it's really useful for bypass surgery. And so you may be depriving a patient of heparin when they don't need to be for the rest of their life. And I guess the third thing is that once you've made a diagnosis of hit, there you go, you can stop, and people stop thinking about why their platelets are low. And actually, you're missing some other diagnosis that may need action for why they've got low platelets, which you've stopped that diagnostic hunt because you've misdiagnosed them with hit. So it is really important that, although we appreciate how dangerous hit can be and how serious it is, and that we convey that to other medical team members or surgical members looking after the patient, it's also really important that we're quite sure that somebody has hit before we go all guns blazing and label them with hit.
Yeah, I guess it's quite hard to come back from there, because the chances of you doing a diagnostic test with here's some heparin, let's see what happens, is going to be unlikely.
Yeah. So the first step in diagnosing hit is to suspect hit, because if you don't think about it, then you won't diagnose it. So that's number one. And then number two is then doing a 4T score. So if you do suspect hit, then the 4T score is basically it's a score that allows you to assess the patient's pre-test probability. And we use this as a tool to basically get rid of the patients that are very unlikely to have hit, so that we don't go on to do tests that may label them positive when they are very unlikely to have it. So we try and get rid of some patients just based on a pre-test probability score right at the beginning, so that we don't end up doing lots of testing in the lab for HIT, because we know that the lab tests are limited in how useful they are.
And the incidence is 0.7%.
Exactly, yeah. So, and then the third thing that we do is we then do an ELISA. So we do an immunoassay in the lab, and that's where we then measure essentially the level of anti-platelet factor 4 antibody in the lab from that patient. And I would describe that really in your head as a screening tool, because again, it's useful for picking up the presence of an antibody, but it doesn't mean that just because you've got antibody, you've got HIT. Because about 15% of all patients that are exposed to heparin will form an antibody. That doesn't mean that 15% of patients exposed to heparin develop HIT. So then after you've done your screening tool, your fourth thing that you're going to do is your confirmatory test. And those are your functional assays. And that's the actual test that will help to actually say whether the antibody that you might have detected in somebody's blood actually equates to the condition heparin-induced thrombocytopenia. So 1, suspect HIT. 2, do the pre-test probability score, which is the 4T score, to rule out people that are unlikely to have HIT. 3, do the ELISA testing, the immunoassays, as a screening tool to look for the presence of the antibody. And then 4 is then functional assay to see whether the antibody detected actually has any clinical relevance, and whether it can actually, mediate this condition. Okay.
Gotcha.
So things that would therefore make you suspect HIT would be if you had a new thrombocytopenia, particularly if you had more than a 50% drop. So it's quite a significant drop in your platelet count for it to be HIT, with a median nadir of 55. So that's quite a low platelet count. You've gone from a normal platelet count of sort of 400, and then it goes down to 55. But note that 55 is not less than 10. So if you've got a platelet count of sort of less than 10, quite a severe thrombocytopenia, then actually that's going to make HIT in the back of your mind less likely. As you said, development of a clot whilst on heparin, that would definitely make you think about HIT. And the other thing that would make my ears prick up, which you talked about, was skin lesions, which are usually at the site of the injection with the heparin. And any systemic reaction post-heparin exposure, if they have like a weird allergic reaction, then that should make you think about the possibility of HIT as well. So let's go into more detail of the famous 4Ts score, which is really important second step in diagnosing HIT by assessing your pre-test probability. So what are the 4Ts? Do you know what they are?
I mean, they're very famous, of course, and I don't really know at all. But
Sorry.
You talked about. I can just repeat the things that I've heard you say. So timing. You talked specifically about the days. Sort of when it was over 10 days, you were sort of less likely, and I'm not sure what the lower limit of that was. And we talked about a thrombocytopenia, which also starts with T, and a thrombosis, so a clot. Perfect. So those are the 3 T's I've come up with.
Yeah, those are the 3 kind of actual T's, and then the 4th T, I say, tell me there's another cause as the final T. Probably other people remember it in a slightly different way, but tell me there's another cause is looking at whether there are other causes for the platelet count dropping. So those are your 4 different parameters. So if we start with timing, basically, your heparin-induced thrombocytopenia will cause a platelet drop to occur between day 5 and day 10 post heparin exposure. Okay. Or less than 24 hours if they've had heparin in the last 30 days. And that's because of the memory cells making the antibody quicker the second time round. Okay.
Yeah.
If it's after day 10, then you will only score 1 point rather than 2 points for that, because it's a bit slow. Or if it's less than 24 hours from the dose of heparin, if they had their last dose of heparin between 30 and 100 days ago, that will score you 1 point as well. So 2 points is the max score. That's day 5 to 10 post heparin exposure, or less than 24 hours if they've had heparin in the last 30 days. 1 point if it's too late, so day 10, after day 10, so day 11, day 12, day 13, okay? Or less than 24 hours if their last dose was between 30 and 100 days ago. But if it's too early, so if you have a drop in your platelet count between day 1 and day 4 post heparin exposure, then you don't get any points, nil point, okay? Because if you think about the mechanism of action, that's just too quick for somebody to be able to form antibodies and the antibodies to be able to make part of the raft with platelet factor 4 and heparin and then activate your platelets and cause them to drop. So you don't get any points if it's too early, okay?
Yeah, that's good.
So that's the first thing. And I would just say that it sounds very simple when you look at it like this, but when you try to apply a clinical case, that's when it becomes more obvious the grey areas about how to interpret the 4Ts and how you would score that patient. And that's one of the big limitations of the 4T score, is this significant inter-rater sort of usability, in that some people might score something for a certain situation, other people might give it a different score. But for example, if you have a patient whose platelet count was already falling before the heparin was started, okay, then actually I would score that patient as a 0, because I would say that the timing is less than 5 days post heparin exposure that the platelet count started to fall. But other people might count that as from the baseline that it was when they started heparin, how many days.
Yeah, it hit 50% at day 5. But
Exactly.
if it was 75% at day 3 and then 60 at day 4, then it's
exactly. And so therein lies the issue with actually using the 4T score in reality. Okay. So for some cases it can be really difficult to know how to apply the 4Ts. But in general, for most people, they're going to start with a normal platelet count, and then the question will be raised that they've had this heparin. And so basically, if it's too early, you're not going to get any points, and you can kind of move on to the next section. But if it's between day 5 to 10, then that's going to get you the full 2 points. And it's really important, therefore, that you really get the calendar up and check how many days post heparin, and you'd be really pedantic about that. And it's also really important that you find out whether they would have had any heparin exposure within the last 30 days or within the last 30 to 100 days. So have they been admitted as an inpatient within that time, or, have they had any other cardiac surgery or whatever? Okay. Then the second T is thrombocytopenia. And as we said, you need a greater than 50% drop, but you need an nadir that's also greater than or equal to 20. So not too low. And if you have both of those together, so more than 50% drop, but higher than or equal to 20 as your absolute platelet count, then it gets you the full 2 points. Okay. If you have a fall that's less than 50%, so 30 to 50% fall, or you have an nadir that's a bit lower than you would be comfortable with, so between 10 and 19, then you only get 1 point. And if you just don't get much of a fall at all, so you've only got less than 30% fall, or you get an nadir that's really low, so less than 10, then that's also unlikely to be hit. And so you get no points for that. So that one's a bit easier. And then thrombosis is the third one. So confirmed clot on heparin gets you 2 points. A suspected clot at the time that you're doing the score gets you 1 point. And obviously 0 points if there's no clot. And just to note that in America, they'll actually do 4 extremity Dopplers to look for thrombosis. So just because someone hasn't been, easily diagnosed with a clot doesn't mean that it doesn't exist. So make sure you do look for it when you're doing your 4Ts. But we wouldn't routinely in the UK do Dopplers for asymptomatic legs or arms. And then the last one is tell me there's another cause. And if there's another cause that's likely, then you get 0 points, okay? And that's where you can use your clinical judgment. So if the patient is working out as quite a high 4T score, but in your heart of hearts, you just think that another cause is more likely, like they've got MDS and they've got an infection, and you think it's a reactive cause is going to be more likely than anything to do with this heparin, then that's where you can say other cause is more likely and give them a 0 at that section. If there's a possible other cause, then it's 1 point. And if there's no other cause, so if you do really feel it might be hit, based on other differentials of a low platelet count, then you can give them a score of 2 for that. Okay.
Makes sense.
And then you tot up your score, and basically what you're really hoping for when you're on call is a score of between 0 to 3. So if you have a score of 0, 1, 2, or 3, then you can say, stop thinking about HIT. This is not HIT. And you can stop at that point. And the reason that you can stop at that point is because the 4T score isn't amazing in that we've already discovered it's quite difficult sometimes to score a patient. And it will be different for different people using the score. And it's got quite a poor positive predictive value in that it's not very good at, if someone is positive on the 4T score, it doesn't mean that they have, that they're truly positive for HIT. Okay. But what it is good at is it's got a really good negative predictive value. Okay. So what I mean by this is it's really good at ruling out HIT. Those that test negative are likely to be truly negative. Okay.
Yeah, I like that.
It's a bit like using the D-dimer.
The dreaded D-dimer. Yeah, that's the one, isn't it?
Yeah. So the 4T score is like the D-dimer of the HIT world. Okay.
Got you.
So if you get a score of 0 to 3, you can stop, and then you just need to think about other differentials for why the patient might have a low platelet count. Think about MAHAs, get a blood film, think about reactive causes, etc. But if you get a score of 4 or above, then actually you need to stop heparin at that point, and you need to move on to the next step. And that's just an important point to dwell on, is that you don't wait to confirm that someone has HIT. If the 4T score suggests a high pretest probability of HIT, then at that point you stop heparin. Because by providing more heparin, you're just fueling the process and you're making them more procoagulant and you're increasing their risk of having a clot. So as soon as you think that they may genuinely have HIT, i.e. they've got a score of 4 or above, then you need to stop heparin and switch to an alternative anticoagulation whilst you do your next tests. Does that make sense?
That does make sense. Yeah.
Perfect. Okay, great. All right. So before we move on from the 4T score, are there any other pre-test probability scores that you've heard of at all?
I'm sure there are tests in intensive care that they use that we've no idea about for patients who are, got lots of other problems going on, and platelets are the least of their worries.
Yeah, that's a really good point, David. And I think that's one of the really annoying things about HIT phone calls when you're on call, is that platelets fall for so many reasons, and especially for patients that are unwell with infection, on medications other than heparin, having intravascular devices, having disseminated intravascular coagulation. There are so many causes for a poorly patient in hospital to have low platelets other than HIT. And so it does make the 4T score a bit difficult to use, particularly for patients that are in intensive care, as you say, because they're really poorly, and so many ICU patients have low platelets, and it doesn't mean that they have HIT from their, hemofiltration circuits. So there was another scoring system developed called the HEP score, which stands for Heparin Expert Probability Score, and it is possibly superior to the 4T score in ICU patients. And basically it specifically itemizes other causes of thrombocytopenia and takes those into account. But unlike HIT, unlike the 4T score, where you've got a really nice table and it's quite easy and you can put it in your notes and you can learn it, the HEP score is quite a lot more complicated, so you would have to use an online calculator to work out what the score is, and it's just, as a result, a bit less accessible and has got a little bit less traction than the 4T score that's been around for a while. So in general, on my on-calls, I still use the 4T score rather than the HEP score.
It wouldn't be like ICU to make life difficult.
Yeah, exactly. So, but it's interesting to maybe do alongside the 4T score, but I don't know how much weighting I would necessarily give it. So yeah. So then we move on to the next test then. So we've said 0 to 3, stop thinking about HIT, 4+, stop heparin, switch to alternative anticoagulation, and move on to the ELISA test. What is an ELISA? Just to make sure you understand the methodology of it in general. What is it, and how would it apply in this situation?
So you might have to correct me if I'm wrong here. From what I understand, there's a a tray with a bunch of wells in it, and the wells have an antigen on them, and you put the patient's sample in there, and if there's any kind of antibody binding, it'll bind to those specific antigens. You then wash it off, and then you put in some kind of fluorochrome, which binds to the sort of the constant region of those antibodies, and hopefully that should then be through a machine and flag it up. Perfect. And say, yes, yeah, I'm here.
Perfect, exactly. So ELISA, which stands for an enzyme-linked immunoassay, basically what you have in this specific situation is platelet factor 4 heparin complexes that are bound to a plastic well. You apply the patient's plasma to allow any anti-platelet factor 4 antibody, anti-platelet factor 4 heparin antibody to bind. You then wash it to remove any unbound antibody, and then you add an anti-human antibody with a marker or a label, like some sort of fluorescent, luminescent type thing. And then you measure the amount of fluorescence or luminescence that's made, okay?
Yeah.
And then
that's what I was going for.
yeah, exactly. That's exactly what you said. So that's perfectly correct. And again, this test has a pretty good negative predictive value of about, over 95%. So if it's negative, it's likely that the patient truly doesn't have any antibody. But the positive predictive value, again, is not great. It's about 70%. And we talked about before the fact that about 15% of patients exposed to heparin make an antibody that doesn't equate to clinical heparin-induced thrombocytopenia. So we do this test hoping, again, that it will be negative and that we can rule that patient out, because a negative ELISA test is more useful than a positive test in this situation. And it's something like only a third of positive ELISA tests for the antibody will actually turn out to be actual hit, even though they found an antibody on the ELISA, just to give you an idea of it. So it's a useful screen, and labs are encouraged to report the level of positivity rather than just positive or negative, okay? So a luminescence of less than 0.6 is generally considered negative, and at that point you can therefore stop testing for hit unless you really feel clinically that it's hit, because they've got like a really high 4T score, for example. And if it's greater than 1.5, then that's generally deemed as a positive test. And so then you need to go on and do functional testing as your last step. And if it's between 0.6 and 1.5, that's a grey area. And depending on the clinical scenario, you may consider going on to do functional testing. And in reality, by this point, we're so desperate to rule it out that we probably would go on to do functional testing so that we know whether this patient is at clot or bleeding risk, basically. Okay?
Yeah.
Any questions about that?
No, that makes sense.
Yeah. Okay. Fab. So, so then we have let's say we have a positive result. Let's say we have a result of 2. What are we going to go on to do with that then, David?
So you mentioned functional assays.
Yeah.
I don't really understand what. I've heard it. It feels like a mixing study of some description, but I don't know.
Okay, so basically, the key concept behind the functional assays is that we now want to show that this patient, who we know has an antibody against platelet factor 4 and heparin, we want to now show that that antibody actually is able to, 1, activate platelets. Okay, so can that antibody that we've detected actually activate platelets, or is it just an antibody that doesn't really do much? And the second thing we want to show is that can it cause aggregation or activation of platelets in a heparin-dependent manner, because we know that that's what happens in HIT, okay? And so to show that it happens in a heparin-dependent manner, we use 3 different test conditions for the functional tests. We have a low concentration of heparin, so 0.1 to 0.5 international units per mil of heparin, so a low concentration. And we should see aggregation at that level, because that's mimicking sort of therapeutic levels of heparin. They're actually quite low concentrations in our blood. Then we use a supratherapeutic level of heparin, so a high dose heparin. so like 100 international units per mil of heparin. And in that situation, we should see that the aggregation is no longer seen because the excess heparin prevents the complex formation. You know, when we were talking about the optimum ratio.
Yeah, the 1-to-1. Yeah.
Exactly. And so the heparin excess is diluting out the complexes. And then we do one with no heparin solution as a control, in which we're just checking that the platelets don't aggregate due to some other cause. Okay. So we basically use our knowledge that there's this sweet spot ratio of heparin to platelet factor 4 that will induce HIT antibodies, which will induce platelet activation. And we use that knowledge to demonstrate whether these antibodies are likely to actually be mediating HIT or not by using a low concentration, which should cause aggregation, and then a high concentration of heparin, which should prevent aggregation or cause it to then become negative. Does that make sense?
Yeah.
And
I mean, I should have got it when you said the word functional. I should have got it.
Yeah. I mean so that's that. Yeah, I guess there's a clue in the name. But then within that kind of umbrella term, we have 3 different kinds of functional assays, which all just differ from each other in how they detect activation of the platelets rather than anything else. So the core concept is the same, but we have 3 different functional assays based on how we detect the platelet activation by the antibody. So the first one is called the HIPAA, also known as Heparin Induced Platelet Activation Assay. That's what it stands for. And this is using light transmission platelet aggregometry, where your aggregation of platelets changes the amount of light that's able to pass through a solution. And then you detect how much light passes through, and that gives you a readout of platelet activation and aggregation. The second one is the serotonin release assay. And this is really quite challenging technically because you have to radiolabel the granules of a platelet by loading the platelet with 14 carbon serotonin. So radioactive serotonin. And then when the platelets become activated, they release those radioactive serotonin containing granules, which you can then detect. And that's, as you can imagine, is difficult to perform. And also handling radioactivity within a lab can cause issues, of health and safety. And so then the third one, which has really taken off, and certainly our hospital use via NHSBT, is using flow cytometry. So it's called the annexin 5 binding assay. And basically, this uses the concept that annexin 5 is like a marker of platelet activation, and will be expressed only on activated platelets. And so you can use a fluorescein that binds annexin 5 and can then be detected via flow to measure platelet activation. And so that's the one that our hospital use. Okay.
Yeah, nice.
So that's it. And so then that will be your ultimate test, which will then tell you whether this is HIT or not. And then obviously you go back to the clinical case, check that all makes sense and that fits clinically. And then at that point, you would then label the patient as having heparin-induced thrombocytopenia. So a lot of steps involved. And actually, the reason that we try and limit the number of functional tests that we do is because they're quite expensive. And they're quite cumbersome, and they're only as good as the kind of clinical scenario that you choose to do them in. So if you can get rid of patients along the way before then, based on the 4T score and based on not having a positive antibody on a simple ELISA, then you limit the number of actual functional HIT tests that you end up needing to do. Does that make sense?
Yes. Yeah. I can imagine you calling the lab at 1 a.m. and asking for an annexin 5, and they will tell you where to go.
Exactly. So that's the thing, and that's the thing that can make HIT really difficult. Is you often end up, because of these lab tests, you often end up having to manage somebody as potentially HIT before you know that it's HIT. And trying to also manage the understanding and expectations of the other clinical teams looking after that patient, because they get a positive result back on an antibody on their path system, and then you have to say, well, no, I know they've got an antibody, but that doesn't necessarily mean this is HIT still. So it's about being able to explain that to the other members of the medical team. But then also explain, but although we don't know if this is HIT, please can you treat it as if it is HIT until we know more. So it can be really difficult, and it does test your communication skills when you're on call sometimes. Okay, so just moving on to the treatment of HIT then. So what steps would you take in somebody that's now been confirmed on an exin 5 flow to have HIT? What would you do?
Priority will be stopping heparin.
Yep, which you hopefully have already done.
Yeah, and making sure they don't get heparin again.
Yeah. Do you know any good ways in which you can do that?
Nope.
So add it as an allergy. Add it as
yeah, okay. Sorry,
you know,
yeah.
like, so add it as a drug allergy. That's something that I always do, and I usually do that myself so that I know it's been done. And also things like provide the patient with a heparin-induced thrombocytopenia card, involve your hemostasis specialist nurses to go and provide information to the patient. So, yep, those are all really important. And this explanation to the patient that they can't ever have heparin again is really important. Good. Then what else?
They are still going to require anticoagulation.
Yeah.
So they're on heparin for a reason, even though it's their post-surgery or what have you. So an alternative anticoagulation, which isn't heparin based.
Yes. Okay, good.
And then I imagine they have a decent risk if they've got memory cells of this reoccurring over the next however long. So I imagine there is a period of anticoagulation for a while.
Yeah, so that's a really important point that a lot of people kind of forget, is that they think, oh, well, they were only being anticoagulated for this post-op period and that's finished now, so job done. But actually, if someone's diagnosed with HIT, they need to be anticoagulated for an entire month after the diagnosis because of how procoagulant it is, which is different to what you would otherwise necessarily normally do. If you've just got somebody post-CABG, you weren't planning to anticoagulate them for a month necessarily afterwards. But if they have HIT, then you do need to. So that's an important difference in management. If they've had a clot, then actually the difference in management is actually not so different, because they just need 3 months of anticoagulation like anybody with a provoked clot. So, but I guess you wouldn't necessarily anticoagulate someone who has an MI or a stroke. But if you think it's related to HIT, then you would, and for 3 months, okay?
Yeah.
And I guess the other thing to just say is, what if you had a patient with HIT who has a platelet count of, let's say, 30? Would you give platelets?
So I guess I'm relatively happy at 30. I've seen worse. And I guess the worst thing I want to do is give them more material to be clotty with. Yeah. So I suspect unless they are, clinically unstable and bleeding all over the place, then I'm unlikely to give platelets.
Yeah, excellent, David. So we don't give platelets in HIT unless there's life-threatening bleeding suspected. So yeah, exactly. But that's important to explicitly say to particularly like our cardiothoracic surgeon colleagues, because you'd be surprised, 30 wouldn't even be a threshold necessarily for us to even want to give platelets in somebody who's not bleeding. But actually that feels scary for surgeons. And they may be tempted to just give them some platelets to correct it, in the meantime, whilst we're waiting for results, sort of thing. Especially when the patient's anticoagulated, that can make people feel really nervous. And usually, if you're anticoagulating somebody, you kind of want platelets above 50. So you can understand how a patient might get a sneaky bag of platelets. So explicitly stating that from the outset, please do not give platelets unless there's life-threatening bleeding, and explaining to your colleagues because they are in a really procoagulant state is really important. Good. Okay. So alternative anticoagulation, you said. What do you think are the options, and what would you be considering when thinking about alternative options to heparin?
So I'm a bit of a loss here. I imagine that warfarin is a no-go, and the only other thing in the back of my head is sort of DOACs. So I don't know.
Okay. Why would you say warfarin is a no-go? It's not related to heparin.
I suppose it's not. Is it? I guess if the platelet count is so rubbish, I don't really want to be giving warfarin on top?
So I think what
I'm clutching here.
No, yeah, and you're getting at an important point, which I just think you can't quite articulate what you're thinking, but what you're thinking makes sense. So essentially, when you've got somebody with a low platelet count and you need to anticoagulate them, it feels a bit scary, doesn't it? Because they've got a bleeding risk. And so what I would suggest in that situation is that you go for something that's got a short half-life, because if they start bleeding, you want to be able to stop it and the drug to be out quite quickly so that they don't bleed to death with their low platelets and their anticoagulation. So that's why you wouldn't, that's one of the reasons why you wouldn't go for warfarin up front in somebody that's just been diagnosed with HIT. And so you want to go for something that's usually intravenous and has a short half-life until they're kind of clinically stable and you're happy that they're not bleeding before you switch to something that's a bit more long-acting. So you're
something that you got control over.
Exactly.
Is what you're saying.
Yeah, exactly. Okay. So your options are argatroban. So argatroban is a direct thrombin inhibitor, and it's solely hepatically metabolized, which is really great for patients that have renal failure, because remember, many of these patients that might have developed HIT will have probably had unfractionated heparin IV due to poor renal function, rather than having low molecular weight heparin, which you can't have if your kidney function is really bad. So it's really useful to have argatroban as an IV direct thrombin inhibitor, which is safe to use in a HIT patient, and is solely hepatically metabolized. It's given as a continuous infusion. So you do an initial APTT before you start the infusion, and that's really important to remember. Get a clotting sample off before you start it. And then you basically repeat the APTT within 2 hours of any dose change, and you target it to an APTT ratio of 1.5 to 3. And the half-life is only 45 minutes. So that means if someone does start bleeding, you just stop it, and within 45 minutes, it's out. Okay. It does mean, because it's hepatically metabolized, that you need to be really careful in liver dysfunction. And also you need to use sort of adjusted doses if the patient's critically unwell or has really bad heart failure. You might want to use a slightly lower dose to start with. But the major advantage is it can be used in renal failure, and it has a really short half-life. And so it's something that I actually would commonly use in somebody with HIT. But just make sure that the team looking after the patient know to do an APTT before they start. Otherwise, it will mess up the whole kind of protocol on how to dose adjust based on the APTT. Okay.
I've never heard of this before. This drug, is this something that's readily available?
Yeah, argatroban generally. Yeah, argatroban generally is, and your trust will have a protocol on how to manage it. Otherwise, if they don't, for whatever reason, there's a good SPC online for argatroban. You will get inevitably quite a lot of calls when you're on call about how to manage an argatroban infusion. So it is worth familiarizing yourself with the protocol, so that in the middle of the night it's not like you having to work it out for the first time.
Yeah. Me on Dr. Google going, help.
yeah, but it is really commonly used because of the short half-life and the fact that it's hepatically metabolized. Then you've got bivalirudin, so that's another one, and that's a direct thrombin inhibitor as well, and that's 20% metabolized by the kidneys and 80% done by enzymic proteolytic degradation, which is not the same as hepatic function. It's done by like enzymes, I don't really know, like on the surface of endothelium and things. So that's useful because you can use it in renal failure and liver failure, although it is 20% metabolized by the kidneys. Its half-life is only 25 minutes, and you can use it intraoperatively on bypass, instead of unfractionated heparin in a patient with a history of HIT, which is useful because of the such short half-life. But it's used less commonly than argatroban. It's less easy to get your hands on. And so I haven't actually looked after a patient on bivalirudin, but I know that you can use it for patients, particularly in surgery, when they're having bypass surgery and they can't have heparin. And then you've got dinaproid, which is a heparinoid, so it's a anti-10A. And even though it's a heparinoid, it doesn't cross-react generally, and so it is safe to use in HIT. But to be honest, I don't know why you would use it, and I haven't seen people use it because the half-life is 24 hours long, and it's IV, so I don't think it's great. So I don't think I would be using that one. So really, it's either going to be argatroban or bivalirudin as your initial IV options. And then later on, when you're happy with how they're doing, that's when you can then move to a subcut or oral option with a therefore usually longer half-life. So you said about warfarin. Warfarin I wouldn't use straight away because of firstly the long half-life, but also initially because of how warfarin works. Obviously it drops your natural anticoagulants before it has an anticoagulant effect, so it drops your proteins CS and Z, and so it can actually increase your risk of microvascular thrombosis initially when your HIT is really active. And so you actually, if a patient is warfarinized whilst diagnosed with HIT, so let's say they were having warfarin and low molecular weight heparin when they were diagnosed with HIT, it should actually be reversed using vitamin K just because of how much of a microvascular thrombosis risk it poses. But it can be used, they say, once your platelet count is above 150, okay? So it's a good option for later on, particularly, again, in your patients with renal failure, because warfarin is safe in renal failure. Something that almost has caught me out before on call is that when you overlap it with argatroban, so let's say you had a patient on dialysis who had unfractionated heparin for whatever reason and developed HIT, and then you go to IV argatroban because you want a nice short half-life of 45 minutes IV, whilst you just settle the patient down and wait for the platelet count to come back up with stopping heparin. Argatroban also affects the INR, so you need to overlap it with warfarin dosing, warfarin loading, when you're happy to move them to warfarin. And the INR should be greater than 4 for at least 2 days before stopping the argatroban, because otherwise what will happen is you'll think the INR is in target for the warfarin, but it's actually the argatroban that's been affecting the INR.
Yeah. I can see how that would catch you out.
Exactly.
And you're like, yeah, sure, go home on 5 milligrams. And then you check them a week
exactly.
later and they're 2. Yeah.
Exactly. So it's just about making sure there's enough overlap because of warfarin being procoagulant to start off with. And then NOACs. NOACs, there's not much evidence for using NOACs in heparin-induced thrombocytopenia, but do we do it in reality? Yes. I think it's reasonable if the patient's clinically stable. The most evidence is with rivaroxaban. So you do your loading rivaroxaban 15 milligrams BD for 3 weeks and then drop down to 20 milligrams once a day. And then the other option that's quite popular is fundaparinux, which again I think is an off-license indication, but fundaparinux is an anti-10A inhibitor. It's a derivative of heparin, but it doesn't cross-react. And it's really easy because you just dose it based on their weight. You don't need to monitor for anything unless you've got clinical concerns. But it wouldn't be an option for your kidney failure patients because it is renally excreted and it has a long half-life, not as long as warfarin, but it still does have a long half-life. So you're not going to want to use fundaparinux until your patient is, very stable. And some people wouldn't want to use it at all because it's not, it's an off-license indication. So those are your options. So initially starting with IV argatroban for particularly renal failure patients or bivalirudin. And then if they're a bit more stable, think about using a NOAC, possibly rivaroxaban, fundaparinux subcut injection or warfarin if they've got renal impairment, and make sure you overlap. And remember, what was the duration that we were going to anticoagulate them for, David?
For a month.
Yeah, perfect. Yeah. Exactly. Or if they've got
you can hear my brain whirring there.
Yeah, no,
she's caught me.
just checking. And then and 3 months if it's just a provoked clot otherwise. Okay.
Yeah.
Okay, so finally I think we should just discuss very briefly HIT in pregnancy. So what drugs do you think would be safe enough to use in pregnancy for HIT as an alternative anticoagulation if it were diagnosed?
So looking at our options from above, I would hope that the argatroban would be fine based on based on it being sort of hepatically metabolized.
Yeah.
I would worry about the biver one because of that sort of enzymatic proteolytic bits.
Yeah.
So I'm not sure about that one.
Yeah.
And then the similar one to heparin seems like it. Yeah, that one was renally excreted as well. So those would be my thoughts.
Yeah, so HIT is uncommon in pregnancy. That's worth saying. So it's even more, it's not like surgery or trauma. But dinaparoid, argatroban, and fundaparanox can all be used in pregnancy. And then warfarin is safe to use in breastfeeding. So you wouldn't use warfarin during pregnancy, because the problem with using warfarin during pregnancy is that you're going to warfarinize the baby as well. And so you're going to put them at risk of bleeding during labor, for example. But postpartum, even if the mother is breastfeeding, there's negligible amounts of warfarin that go out into the breast milk, so you can use warfarin in that situation post delivery. Okay, good. And then lastly, I guess in cardiac surgery, do you know if you can ever, is it definitely a no to give unfractionated heparin just during the intraoperative period in patients that have had a history of previous HIT?
Well, thinking out loud, if it still takes 1 day for them to produce the antibodies, even if they've got a memory cell kind of thing going on, in a desperate scenario, I imagine you probably could use it intraoperatively, as long as you're ready to deal with the aftermath afterwards.
Yeah, you're kind of right. So what you can do is if a patient's got a previous history of HIT, you can do the ELISA to see if they have the antibodies and do the function test to see if they have the antibody. And if they are antibody negative, then you can consider using intraoperative unfractionated heparin. And then use something else alternative before and after the operation. But if they've got positive antibodies, then you generally wouldn't re-expose them, because you're just going to run into clotting issues post-operatively, because you've stimulated.
What's the half-life for? How long do antibodies hang around for?
Gosh, I've no idea. In the actual HIT antibodies, they tend to disappear at about 50 to 80 days generally, like median amount of time. So therefore that's why, if after 100 days of having had HIT, you're likely to be antibody negative, and therefore intraoperative unfractionated heparin may well be an option just during the operation period itself. But if you find that they are still positive, then you shouldn't be exposing them to heparin of any kind for any amount of time, really. Okay.
Yeah, got you.
Great. All right. Well, that's it. That's HIT in a nutshell, from lab to clinical. Shall we wrap up with?
I was going to say, I think it's time that you wrap that up for our 3 golden nuggets of HIT goodness.
Okay, so firstly, HIT is a haematological emergency due to it being such a procoagulant condition, despite a low platelet count. And that's important for you to get your head around, and it's important for you to get the treating team to get their head around and to appreciate and understand, therefore, that they shouldn't be giving platelets unless someone has life-threatening bleeding in HIT. Secondly, I would say it's probably not HIT, okay? Most of the time that you're called, it isn't HIT. And I would really recommend that you do the 4T score really carefully, and that you discuss that with your colleagues, because of the user variability and how you apply that score, to get a sort of general consensus as to whether you're using the score appropriately for that clinical scenario. And make sure you calculate the 4T score yourself. I've definitely had phone calls before where someone has phoned me and said, I've calculated the 4T score and it's coming out at 8. But actually, when you calculate it, it's coming out at 3. And lastly, if you do score 4 or more, then make sure you stop the heparin. Do not wait for your ELISA and your functional test. Stop the heparin, seek alternative anticoagulation, and make sure you do that for at least a month. And then don't forget to put heparin for those that are diagnosed with HIT on the allergy status, give them a card, and get the hemostasis nurses to see them. And they probably need some sort of follow-up in a haematology clinic as well. So That's not really 3 points, is it? That's more than 3, but those would be my key.
We can pretend. We'll take them.
Yeah, my pretend 3 points. Yeah. Great.
Thanks very much then, Harrod. That's great.
Yeah, okay, great. All right, so good luck, and next time you get called about HIT, when you start your on-calls, you'll be ready.
Because I'm desperately trying to remember my 4Ts. Yeah, I'll be good.
All right, see you later.
Cheers.
Bye. Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.